Hey, Dr. C here with you. This is a really important topic that I'm excited to share with you, and this is autoimmune gastritis. Now, it's important because so many people with thyroid disease, they've got unresolved symptoms, and they've often been left to think that the right, feeling better is just a pill away, that there's the right pill, the right amount, and suddenly things will all be okay. But all too often, people have tried tons of pills and tons of potencies, and they've not gotten better. Even if their thyroid labs are dialed in, they're not yet feeling their best. And in these cases, we're thinking about a secondary condition. The majority of people with thyroid disease have some additional condition that commonly pairs up with it. And this is amongst the most common. So autoimmune gastritis, we think about this a lot if you've got certain symptoms. So fatigue, hair loss, gastrointestinal symptoms, gas, bloating, heartburn, irregular stools, or you keep getting yeast overgrowth, or you get bowel infections. These are the times we think about that. Or if your nutrients are always low, like your iron is down and it can't come up, you're B12 deficient. We think about this especially in those types of cases. So let's get some general context. How common is autoimmune gastritis? Well, it's pretty common stuff. So most people that have it don't have any obvious symptoms. So the problem with that is many go underdiagnosed. But a couple of bigger studies have just grabbed people, just adults, and then checked them and screened them for this, for the purposes of seeing how prevalent it is. And it can be about 20% of adult populations that can have this. Now, if we talk about those that we know have thyroid disease, then that 20% goes up to 30 to 40%. It's crazy common. 30 to 40% of people who have thyroid disease also have autoimmune gastritis. And if we go vice versa, if we say those that we know have autoimmune gastritis, how many of them have thyroid disease? Well, that's 53%. So there's this huge overlap. And that's why this has been called autoimmune thyrogastric gastritis, because these things tie together just so strongly. Now, we think about this especially when we see thyroid disease come on postpartum. That's one of the most common scenarios. But it can be anyone with thyroid disease regardless of the age. And it's actually more common amongst those who are a little younger, more common amongst women, and just especially prevalent in those who have milder levels of the digestive disease. So the risks are higher with other autoimmune disease as well. Type 1 diabetes, vitiligo, Addison's disease, but none of those have as strong of an overlap as thyroid disease does. So what symptoms of this disease would someone have? And this is fascinating. Until I dug deep to put this blog post together, I was under the impression that most don't have symptoms. And you'll see most reports on atrophic gastritis say just that people that have this don't really have symptoms. But many do. I saw a big paper looking at this exact question. And it turns out that at least half of people with autoimmune gastritis do have symptoms. Now, these symptoms can be in the upper intestinal tract or the lower intestinal tract. So upper intestinal tract, that's where it's most common. And we think there about like heartburn, difficulty swallowing, stomach pain, nausea, vomiting, feeling like things are stuck, going down. And think about how common some of those symptoms can be with thyroid disease. We often blame that on the thyroid being enlarged. Another group can have more so lower gastrointestinal symptoms. Here we think about like abdominal pain or discomfort, gas, bloating, alternating between diarrhea, constipation, even accidental stool leakage or incontinence. And then a final group of people can have symptoms in both areas, so both upper and lower. And yeah, those who are the most symptomatic were commonly under the age of 55, oddly enough, more commonly non-smokers and female, and not yet anemic. So those are the earlier stages of the disease. Now gastritis in general, so not the autoimmune gastritis, but gastritis in general can also be caused by Helicobacter pylori. So if we see that someone has gastritis because they've had heartburn, they've had low nutrients, we do want to think that H. pylori could be a culprit. But the symptoms are usually a little bit different then. It's often more pronounced that they can have ulcers, dramatic heartburn, vomiting, unexpected weight loss, loss of appetite. That's a slightly more common symptom profile. However, the good thorough screening for autoimmune gastritis would also look for H. pylori. Now, how does this affect our health? Well, in general, the damage from autoimmunity to the stomach lining makes it to where we're not producing adequate stomach acid. And that can cause us to not be able to absorb nutrients. That can also change our bowel flora. We hear about lactobacillus acidophilus, so like acid loving. And many of the good bacteria we have, they need that blast of acid from the stomach to make the world safe for them, to make it to where they like it and the things that hurt them don't like it, right? So when stomach acid is lacking, a lot of these things can go wrong. And think about how Hashimoto's, how it damages the thyroid till it can't put out hormone. So with autoimmune gastritis, that immune response damages the stomach, so it can't produce its hydrochloric acid as well. And when things do go wrong, one of the first things that happen is iron levels start to creep down. And that's often one of the first ways we think about this. Someone's low in iron in ways we wouldn't explain otherwise. And that by itself causes many symptoms. People can have chest pain, vague fatigue. Here's a couple that are more specific: tinnitus, the ringing sound in the ears, lightheadedness, heart palpitations, insomnia, muscle pain, hair loss. These can all be related to iron levels. As the disease progresses, it can also affect B12 absorption. And at that point, we can also see more dramatic brain fog, confusion, dizziness and unsteadiness, tingling in the arms and the legs. And again, this is really because of the damage to the parietal cells. And because there can be a lack of proper acid secretion, we'll also see changes in the health of the bowel flora and overall absorption of other things like proteins. So if you have a hard time digesting proteins, if you're reactive to supplements, this is stuff to consider. But they have shown that there can be streptococcal overgrowth and distinctions in the bowel flora. We know as well that there can be regional damage to parts of the stomach, especially the latter portions of that. And then the big risk is long-term for stomach and esophageal cancer risks. So why does this happen? Well, there's not a clear answer. We just know that there's so much overlap with autoimmune thyroid disease. We do know that people can have similar symptoms with H. pylori. Again, that's different. So if someone has iron deficiency anemias, B12 anemias, heartburn, yeah, we think about gastritis. And in that case, we want to screen for markers of autoimmune gastritis, which I'll talk about. We also want to screen for H. pylori. Now, if someone does have H. pylori, by and large, that's treated, antibiotics, natural compounds. However, when it's gone and it's successfully eradicated, we expect the stomach to heal. Autoimmune gastritis, not so much. It does persist. So we diagnose that first by screening for the antibodies. And these are parietal cell antibodies. To be really precise, we're doing an ELISA test for gastric HK ATPase. That's the subtype that's most meaningful. There are also intrinsic factor antibodies that are useful. And those tests, they're showing the whole autoimmune response. Now, a good screen also can show by blood markers if there is significant damage that's occurring to the stomach. And that's shown by gastrin and by pepsinogen 1 and 2 ratios. The latter, not always commercially available, but if so, can be helpful. So yeah, the test can show both the autoimmunity and also if there's been significant damage that's taken place. And if we do see signs of there being some damage present, then that's appropriate for screening as well with an endoscopy to visually look and sample some portions of the stomach. A good screen will also make sense out of the nutrients that could be low if that's not already been done. So you want a good iron panel, ferritin, TIBC, serum iron, percent saturations, and a blood count. We do also want a serum B12, and there are some ways in which that can be read with more nuance. I'll talk about that elsewhere. And then, yeah, for those who it's appropriate, we think about there being an endoscopy and possibly a biopsy. That's especially relevant if we do see that they have overt iron deficiency anemia and or B12 anemia and high levels of gastrin. Once that's been done, that's smart to recheck on a 3-year cycle, just because there can be progression. Now, kind of a cool thing to be aware of, there is a thing called a virtual biopsy, or like a serum biopsy, which means a blood test. And that's all the tests I mentioned before, plus one called gastrin 17. And that's one of the more sensitive indicators of damage to the stomach. Not in the USA at this point, hopefully soon, but they do have that available in Europe. So how does this condition progress? Well, here's the thing. For 1 or 2 decades, there can be measurable antibodies and the disease is actively occurring, but there's no obvious symptoms and no overt measurable damage to the stomach. It's just starting, it's in the wings. We can start seeing there be some lack of iron. So not so much overt anemia, but we could have low latent iron depletion. The iron stores, the ferritin, is creeping down before the hemoglobin or the red blood cells compromise. So that can happen in the first couple of decades. At that point, we generally don't see gastrin elevated. There's no progressed signs of stomach damage. The next step is then gastrin does elevate. And often from that damage, we'll start then seeing iron deficiency anemias and B12 levels running low. And that can go on at that level for many, many years at those various stages. Oftentimes, by the time B12 gets low, that's generally one of the later stages. When we see that show up, someone often does have some pretty marked damage to their stomach, and they're often later in life for that. And the long-term risks are really the esophageal cancer and the gastric cancer. And we manage those risks just by screening and making sure someone has not shown progression. Now, here's a paradox about this condition, is that the parietal cells, they're damaged and the stomach can't make adequate acid. However, those cells, they also make bicarbonate buffer and mucin. These are the things that protect the stomach from acid. So you're lower in acid, it's bad, but you're also more fragile and more apt to become damaged by acid. So antacids actually aren't a good idea because they worsen that part of it. However, acid supplements are also not a good idea because they worsen the damage side of it. Your body can't protect itself against the acid. So I think a lot about the popularity of taking HCl as a pill for those that have thyroid disease. And I'm sure that there are many people that have had undiagnosed autoimmune gastritis, and they had all these classic symptoms. They had difficulty digesting big, heavy meals. They had a hard time with many supplements. They had gas, bloating, heartburn, and they probably felt better in the short term by taking acid pills. It did help them absorb nutrients. It could have helped them with their flora. However, their bodies can't tolerate that. If they took enough to make a real difference, we would expect that they would also be damaging their stomach and accelerating their path towards gastric cancer. That's why data is so critical, and the symptoms matter, but how you feel in the short term is not always an accurate gauge of what's really going on in your body. There's a thing that's actually called the titration test, the tolerance test. And I was taught this way back in the day. The basic idea was you keep taking hydrochloric acid pills until you feel warm or burning, and then that's your dose, or like just below that's your dose. And it makes intuitive sense, but now that I understand the real story behind autoimmune gastritis, it just terrifies me to think that many people are following that strategy, that they're taking all this stuff right to the threshold of heartburn. Another thing occurring with autoimmune gastritis is that any sense of innervation, how well you could feel what's happening in your stomach, that can also be compromised. So if it were burning, you may not feel that as readily. And yeah, ongoing heartburn, that's cancer risk. That's still one of our bigger causes of death is stomach, colorectal, gastrointestinal cancers. We don't want to have you risking that. So the main thing really is screening and then watching these big nutrients. And there's some nutrients that with autoimmune gastritis, you're not going to reverse the deficiency by taking them orally. It just won't work. However, in many cases, once you've repleted your stores and gotten built up again, you can maintain by some version of oral supplementation and diet. But iron, B12, those two, especially iron, when someone really gets low, the math just doesn't work for them to reverse that by diet or supplements. They need a few doses of intravenous iron. And the cool thing is that can be done in a way to where they've got like years worth of deficiencies reversed in half an hour. It's like the coolest thing. They can have it safely topped right back up again. And this is true for B12 as well. Your body can store that. You can use B12 orally in many cases, often not enough to reverse a bad deficiency, but generally enough to maintain that. So yeah, a huge part of well-being and improvement for those who have this is watching those nutrients, getting them corrected and getting them stable. And that can be life-changing. You know, that's the biggest source of so many of these symptoms, is these critical nutrients that are lacking. These things the body just needs so badly that it cannot get in. This can also be why protein requirements do differ, because proteins can take longer to break down. But by and large, with easy digestible proteins, powdered forms, a variety of food forms, and perhaps if it's not completely broken down, we then adjust the total protein intake to compensate. So if someone needs 90 grams, maybe now they want to do 100 grams, just for that 10% they might not get in otherwise. But by and large, with these steps, you can feel well from this, you can feel fine. But without knowing, there could be risks and there could be problems that would never be resolved. Last thing is, this can be part of it where people seem to have a hard time absorbing their thyroid medication. If their levels radically fluctuate for no clear reason, or they're on a dose that seems to be a lot higher than they would need just to break even, this could be why. So if any of the things apply to you, let's get you screened. All the IH docs can easily make sense out of this. It's blood tests for most people. It's some simple blood tests, and we know it's there. We want to just stay on top of it and work around it and keep you healthy, keep you feeling your best and getting you back on track again. That's what it's all about. All right, Dr. C with you. Take great care. I'll see you real soon. Bye-bye.